Good evening, everyone, and I'm Dr. 𝐂𝐚𝐧𝐭 𝐿. I'm a oncologist in Narayana Hospital, Kolkata, and R.N. Tagore Hospital also. I work in two hospitals of a single center. Well, today, I am assigned to speak something of colon and rectal cancer. I'll be taking some 15 minutes to understand the basics of colorectal cancer. So, what is this? I understand that the audience are general people and laymen with some minimal knowledge on cancer. So, well, if you look into colon is that part of the gastrointestinal tract. For example, if we eat food, it needs to be digested. The initial digestion happens in the stomach, and then comes the small intestine where the further digestion happens. And in the small intestine, whatever food we have eaten is still in the liquid form. So to absorb the important component of food and to make what is known as a formed stool is basically the job of a colon. Colon basically helps in making a formed stool by absorbing important nutritional components and the fluid aspect of the stool, and resulting in a formed stool is basically the contribution by colon. And the last part of the colon, which is in contact with the anal canal, the opening, the lower opening of the GIT is called the anal canal. So if you look into the parts of the colon, we have the right colon or the ascending colon that is going up. And then we have the transverse colon that is horizontal. We have a descending colon or the left colon. And then we have a sigmoid colon. And then we have the rectum and the anus. Very importantly, in colorectal cancer, we divide the colon into right and left. The ascending colon and the right 2/3 of the transverse colon, again it may change, will become the right part. So you can say half of the right, the ascending colon, half of the transverse colon is the right part, and the left part is mainly the left part of the transverse colon, the descending colon, sigmoid colon, and rectum. So right colon cancers are bad. Left colon cancers are better, in the sense they are not that bad. And more importantly, right colon cancer presents with bleeding or blood loss. They don't usually cause obstruction. For example, in a 70-year-old man coming to you with repeated fall in hemoglobin or low hemoglobin, we always look into a primary in the right colon. They are not obstructive. The left colon presents with obstruction. They come with abdominal distension, abdominal pain, difficulty in passing stools, and so on. And a rectal cancer, if you look, the terminal part of the colon, which is called the rectum, they usually present with bleeding in the anal, bleeding in stools, is how a rectal cancer presents with. So, right colon presents with weight loss, low hemoglobin, diffuse symptoms, whereas left colon presents to you with obstructive symptoms, and rectum presents to you with bleeding. So these are the important differences of different parts of the colon. So we know the incidence of any cancer, and especially the colon and rectal cancer, is significant in India and elsewhere also. So very important is, to whom does this colon cancer happen? who are the people who are at risk? Cancer is a disease where we don't have one-to-one causation. For example, COVID-19, coronavirus causes COVID-19. We have one-to-one causation. Mycobacterium causes tuberculosis. This is in infections where we know the exact cause of disease. Whereas for diseases like cancer, diabetes, hypertension, we don't have one-to-one cause. We can only say the probable risk factors for them. So among the risk factors, what we have some risk factors which we cannot change. For example, age. Me getting older is not possible to be changed. Family history, I cannot change. Whereas I can change some risk factors. For example, obesity, smoking, taking a lot of red meat or processed meat. Processed meat is a big risk factor for colon cancer, and lack of physical activity, and eating lot of junk food, that is lacking fibers. These are all harmful and they cause colon cancer. So non-modifiable, which I cannot change. Age and family history, I can't do anything. Only thing is I can get myself into a high-risk screening protocol if I have a family history. Whereas if there is no family history and if I am not able to control the non-modifiable risk factors, then I must work on the modifiable risk factors. What are those modifiable risk factors? Number one, I should not smoke. I should not drink. I should have proper physical activity. I should maintain a proper body weight. And very importantly, a proper diet, a diet rich in fresh fruits and vegetables with lot of fiber. We should not eat processed food. That food which is very tasty like pizza and burgers or a processed meat. These are harmful for the colon. It is said that the processed meat is as harmful as cigarette smoking. Therefore, we must focus and eat as much high fiber and fresh diet as possible rather than eating a processed meat or a processed diet. So this is how I must work on the avoiding the modifiable risk factors. Okay. So these are the symptoms which I was going into: weight loss, low hemoglobin. These are the part of right colon, left colon, obstruction, blood in stool, and so on. And abnormal bowel habits. So we should not worry if I have a constipation for one day, I should not worry. We all know how our bowel habits are. Either we are active in the morning hours or in the afternoon hours and so on. So if there is a change in my routine bowel habits, and if it persists for more than 4 to 6 weeks, then only I must be alarmed about these symptoms. So these are the important symptoms, or what I call as red flag signs of colon cancer or rectal cancer. If I have any one of them, and if it is persisting for more than 1 month, then only they become red flag signs. So if I have low hemoglobin, if an elderly gentleman has low hemoglobin and we are not able to identify, it's an important risk factor. Number two, if there is a bleeding in the rectum, which is persisting, if you have a hard stool and you had a blood in stool for 1 day, that will not qualify for cancer. It should be persisting for at least a month or so. And then weight loss, unintentional, we do not know. Change in bowel habits or obstruction, constipation or diarrhea, which was not there before and it is persisting over a month, then also. So we should think of these 5 danger signs or red flag signs for colon or rectal cancer. Okay. Blood in stools, low hemoglobin, change in bowel habit, weight loss, abdominal pain. These are important obstruction. These are the important danger signs for colorectal cancer. And this is what you can see. Blood in stools for one day, you should not worry. If it is persisting for over a month, then only it's important to worry. So this is what I was saying. Change in bowel habits, important. Weight loss, danger sign. Abdominal pain, danger sign. Again, persisting. Anemia, we don't know the cause. Again, important. Fatigue and loss of appetite, another important. Danger signs of any cancer, for example, but colon cancer in particular. I think you have remembered the danger signs of colon cancer. So what to do if we have any one of these danger signs? We do some important simple tests. We test for, is there a presence of blood in stool? At times we call it as occult blood test. If it is present, it may indicate that there is some amount of bleed happening. That's all we understand. To understand whether there is colon cancer, we can do what is called as a scopy. For gastritis or gastric problem, we do an endoscopy also called upper GI endoscopy. For bleeding from rectum or lower GI problem, we do what is called colonoscopy. It's a simple OPD procedure where we are asked to eat a lot of purgatives or laxatives. We empty the bowel and under light sedation, we do a colonoscopy. We go right from the rectum and then we go to the descending colon and then we go to the transverse colon, ascending colon, when we go up to the cecum. This is called a complete colonoscopy. It's a painless procedure, a bit of discomfort, but with sedation, it should be okay. So by doing this, we can pick up even a minute problem in colon. Even a small polyp can be picked up. What is a polyp? Polyp is just a bulge seen in the colon mucosa. Remember one thing, all polyps are not cancers, but majority of cancers arise out of polyps. Very important. All polyps are not cancers, but all cancers usually arise from polyps. However, there is exception. For example, in a Lynch syndrome patient, we call non-polyposis. Without a polyp, there can be cancer. But very important, cancer of colon doesn't happen in a day or in a month. It will give you time. It will initially become a polyp and then it will show a transformation to cancer. That means you have plenty of time before this colon cancer actually spreads elsewhere. Therefore, with these early symptoms, whatever I said, the danger signs, bleeding in stool or abdominal pain or weight loss, all these, if it is there, change in bowel habits, if these are there, if you go immediately to the doctor, you will be able to diagnose colon cancer early, because majority of colon cancer arise from the polyp and there is plenty of time. You have 3 to 4 years time at least before the polyp becomes cancer. Therefore, we should not miss this opportunity of a danger sign in the initial part of symptoms. Okay. So going further, so I can either test the stool, I can do a colonoscopy. That is very simple and clear. So these are the types of screening we have. We have barium enema, sigmoidoscopy. Enema is all obsolete and we hardly do right nowadays. We do sigmoidoscopy, colonoscopy, which is very simple and not expensive also. It can be done in an OPD procedure. It hardly takes around 30-35 minutes time with a proper preparation. The other ones are like a CT scan we can do with the oral contrast or IV contrast. We can see them, but they are done not to understand the mucosa, to understand the neighboring structures. Has it spread to other organs or not, we do CT scan. Otherwise, colonoscopy is an excellent procedure to pick up an early colon cancer. So, well, for any cancer, if you look into, even colon cancer also has 4 stages. Stage 1 is when it is confined to the mucosa. Stage 2 is it has gone into the muscle, but it has not ruptured the outer layer or serosa. And then we have stage 3 is where we have lymph nodes nearby. And stage 4 is where it is spread to other organs. The usual organs are liver and lung. This is the organs it spreads. So very important is, it is very important to pick up the warning sign and pick it up even before stage 1, or what you call as an in situ cancer, or at least in stage 1, where a small polyp is there was a bleed, and you went to the doctor, did a colonoscopy, and the polyp was plucked completely, derooted. So this is how we treat early diagnosis, early management. So with stage 1 and stage 2, where the lymph nodes are not involved, only surgery is sufficient. There is no need of anything else. The polyp is there, remove the polyp, or the tumor is confined to the muscle, then just remove it or give some oral tablets. If it is stage 3, then you know you need surgery, and also some chemotherapy is required. In case of rectum, rectum is an important organ. Why is rectum an important organ? Because when we feel the sense of defecation, we must be able to hold it, what we call as continence. We should have a voluntary control of passing our stool. That is why rectum is important. When there is a rectal cancer, what we used to do before was remove the rectum completely. And the person had to stay with a colostomy bag throughout his life. Now, this is no longer existing. What we do nowadays is an organ preservation. We don't remove the rectum completely. We give radiation and tablets and melt the tumor in the rectum. We preserve the rectum and we remove only the tumor. So in the present day, in a rectal cancer, there is no need for the patient or for the individual to get the rectum removed. He can have a normal life without a colostomy and can have a normal passage of stool after completing treatment. So this is what is known as organ preservation in rectal cancer. So this is about stage 1, stage 2, and stage 3. Coming on to stage 4. Well, if you look into stage 4 disease, we have 2 types of treatment. Chemotherapy anyways works here. And very importantly, we have something called targeted therapy and immunotherapy. These have revolutionized colon cancer management. So these are the treatment options which I was saying. Polypectomy in stage 0, even before the mucosa is involved, the carcinoma in situ can be handled. And then stage 1, 2, 3, and 4. So the more the stage, you need more treatment. If you are in stage 2, you need surgery, and you may need tablets also. And if you are in stage 3, you need surgery, chemo, so much treatment. Higher the stage, more the procedure, more the expense, less the result. Therefore, the key is early diagnosis and treatment. And the best is to prevent or to adapt lifestyle so that we don't develop colon cancer. Well, quickly going on to stage 4 colon cancer. So this is what is polypectomy. Go with the first danger sign, you will be able to get it done. And then we have laparoscopic surgery, no cutting, only through 2 holes. You can get the tumor completely removed. And this is what I was saying about the stoma and the colostomy. Stage 4, there was a time in colon cancer, stage 4, where we said, whether you take treatment or you don't take treatment, you're going to live for 3 months. Therefore, we used to send the patient back home. Okay, you are not going to live more than 3 months. There is no more treatment required. Colon cancer is one cancer where we offer surgery even after it has spread to the neighboring organs. Even in a stage 4 disease, we offer surgery in colon cancer. If there is a colon cancer and it has spread to liver and lung, and if we can operate them, we must operate them. This is the beauty of colon cancer. This is in contrast to all other cancers where the moment it is metastatic, we don't operate. Whereas in colon cancer, we operate the primary and also the metastasis. This is because we have effective systemic therapy, excellent injections which give wonderful responses. We have chemotherapy and targeted therapy combinations can cause 70 to 75% response rates. Even a lymphoma may not respond to that extent. That is the amount of response rate we get when you use a triplet chemotherapy with an anti-EGFR. Wonderful response rate in clinical data. So if you want to shrink, it is anti-EGFR. And I will speak of one molecule called bevacizumab. Bevacizumab is a molecule which has no direct anti-cancer action, but it reduces the blood supply of the colon cancer cells so that the colon cancer cells do not get blood, do not get oxygen, and do not get nutrition, and the cancer cells die. What we call as anti-VEGF therapy. So this is, and then comes an era of immunotherapy, especially in those patients who have a family history, right-sided colon. They have something called as a microsatellite unstable tumors, which are amenable to immunotherapy. No chemo, no target therapy, only immunotherapy. And the patient has an excellent quality of life. So in MSI high tumors, immunotherapy has revolutionized anti-cancer treatment. So well, with this, I would want to complete my talk on what I have displayed on the screen. Having a high fiber diet rich in fresh fruits and vegetables is the way to go and is the only way to win colon cancer. These are modifiable risk factors. Processed meat is as dangerous as smoking, and therefore it has to be completely avoided. It is like a poison, and we must avoid by all means. By having a healthy lifestyle, healthy diet, and by knowing these 5 warning symptoms of colon cancer, and by going to the doctor at the earliest stage, we can get rid of this disease in majority of instances. Well, having said that, even if we have one of us or one of them known to us has been treated with 4th-stage colon cancer, we need not have to be disheartened because we have excellent treatments including chemotherapy, targeted therapy, and immunotherapy. So with this, I would thank all of you for patient listening, and I thank for this opportunity for putting my few words onto you. Thank you.
Thank you, sir. Thank you very much for enlightening us on colorectal awareness. Thank you very much, sir. Thanks for the time, sir.
Okay.